Hello everyone, my name is James Swinton. I am Second Vice President of Underwriting Risk Management at Munich Re. Sitting with me is our Chief Research Medical Director for North American Operations, Dr. Robert Lund. Rob has been with Munich Re for over 14 years. He was very instrumental in conducting the research for the newly revised breast cancer section in our underwriting manual, EDGE. I'd like to welcome you to today's discussion with Dr. Lund about his research and findings. Before we start the question and answer session, I would like to share with you a little about recent updates to our EDGE Life Underwriting Manual. Since its introduction in 2010, the EDGE manual has been updated semi-annually. Our most recent updates to the Life Manual include a new mature age section featuring a calculator for cognitive and functional assessment and a new tumor calculator for melanoma and prostate cancer. We've also updated some non-medical sections such as scuba diving, auto racing, and mountain climbing. In late October, we introduced significant changes to the breast cancer section. These changes, which we are discussing today, recognize the recent improvements in the outcome for breast cancer survivors. Rob, please tell us a little about your research and the resources you used.
The new breast cancer section was constructed from researching the current scientific medical literature and also evaluating mortality statistics found in the SEER database. SEER is an acronym, S-E-E-R, that stands for Surveillance, Epidemiology, and End Result. It's the cancer registry for the National Cancer Institute of the U.S. Started in 1973, it now encompasses about 28% of the United States population.
I noticed we have moved from the traditional flat extra structure to table ratings for this type cancer. Why was this change made?
Traditionally, when people were evaluated for mortality risk with breast cancers such as the one that we see here, the initial survival curve is quite steep, represented here by the blue diamonds. Not only steep and concave, so the traditional way that this was dealt with was to postpone these people for some years until the steepness of the mortality curves or survival curve starts to flatten out a little bit. In this instance, about year 4. This represents a T2 cancer that has positive lymph nodes. However, in the earlier stages, we find that this pattern really does not represent early stage breast cancer. Now here we see in the lower right-hand corner, this is a T1C breast cancer with negative nodes. That would be a cancer of 1.1 to 2 centimeters, somewhere in that size range. And we can see that really the survival curve is not concave, but convex. Again, the breast cancer survival is represented by the blue diamonds. And we can see that the two curves really don't even begin to separate until about year 6 or so. Now, if we look at the grid on the left, this is a proposed scheme that might cover this particular cancer because, as we can see in the upper right-hand corner, the total excess deaths here, postponing this cancer from evaluation for the first 2 years, are about 71 per 1,000. And so traditionally in the industry, we would devise this sort of pattern as we see in the grid. Year 2 to 3, 15 per M for 5 years. Year 3 to 4, 12.5 per M for 4 years, and so forth. This tapering pattern of flat extras. But if we see how this works, and then we look at the survival curve, we see that there's a disconnect. The initial expression of excess mortality really doesn't occur until about year 6, at which point we can see that the flat extra assessment really wouldn't cover. And also we can see that really the flat extra assessment covers only for maybe the intervals year 2 to 3 and 3 to 4. The other thing we can see from this slide is that the excess deaths really never go away. And again, this is a T1C lesion, as we can see in the upper right grid, which represents raw excess deaths over a period of follow-up of about 19 years. We'll talk more about this phenomenon later.
What effect have clinical screening recommendations had on breast cancer diagnosis?
With the advent of routine screening mammography in the mid-1980s, we have seen a progressive increase in the incidence of early stage, that is again size T1 and T2 cancers being diagnosed. Here we can see a progressive rise all the way until about year 2000, at which time early stage breast cancer had been doubled in its annual incidence. We see that the late stage cancers really haven't changed much as far as occurrence over the last 20 years. Of course, the early stage cancers are the ones that are most readily underwritable, and we can see that we're going to be encountering those much more often. This next slide shows a relative frequency of distribution by age band of the different T1 and also T2 size lesions. We can see that the T1C cancer size, that is 1.1 to 2 centimeters, is the most numerous in age band 15 to 69 years, which of course is a prime age for insurance application. So these early stage cancers have increased in incidence, and they are occurring in ages where we frequently underwrite people. One effect of this increase in diagnosis of early stages is basically that there is increase in lead time over the natural history of the development of the course of these cancers. Now we know the diagnosis earlier, and also treatment has been more efficacious, so that the period when excess mortality becomes expressed has been prolonged outwards a little bit. This result is, as we see in this slide, the initial 6 or 7 years for a T1C cancer with negative lymph nodes really are associated with no appreciable increased mortality. This sort of curve certainly does not lend itself to a temporary flat extra underwriting format.
Rob, I notice there are significant changes, especially with T1 and T2 tumors, which more favorable offers, even standard offers, can be made much sooner after treatment. Please tell us about these changes.
That's very true, and it is concerned with the survival pattern of early stage breast cancer, which really doesn't vary that much from other impairments that we underwrite with table ratings. For example, here we see on the left a survival curve of 20 years for individuals undergoing surgical repair of the mitral valve. The age group is 58 years, mortality ratio is 31%. On the right, we see a T2N0 breast cancer, grade 1 and 2, same age group that demonstrates over 19 years a mortality ratio of 134%, roughly the same. We underwrite one with a table rating. Why would we not use a table rating on the other, particularly since there is no early concavity to the breast cancer survival curve? Another aspect of this is because there is no steep early mortality, there really isn't that much advantage to having a multiple year postponed period. And so we've done away with our postponed period except for the initial year after completion of treatment for our early stage breast cancers, which will enable much earlier and more competitive offers. Here's another example. We have on the left diabetics in their early 50s, male diabetics followed for 15 years. And on the right, we have a T2 grade 3 breast cancer, same age group, followed for about 19 years. And we can see that table ratings are certainly sufficient to underwrite either of these groups.
In one of your slides, it appears that excess mortality from breast cancer never completely goes away. Is this correct?
That's true. And this has been the topic of some of the recent clinical literature as well. Now, here is a slide, again, with our T1C lesion, grade 1 and 2. And on the left, we see the excess deaths persist out over 19 years. The survival curves on the right, we see that the blue diamonds, that is those with cancer relative to the red squares, the expected population, begin separating, as we've noted, around year 6 or 7. And they continue to slightly separate over time for the most part, indicating that excess deaths persist. Here's another example. This is a T2 lesion, and we can see that not only do they persist, but they actually increase over time.
Why are the excess deaths persisting?
First of all, the very nature of breast cancer is associated with some chronic increased mortality, As we all know, along with cutaneous melanoma, breast cancer is the other cancer notorious for a late recurrence. There is increased risk for cancer to develop in the contralateral breast in women that have had breast cancer. So there is some increased mortality in this regard. But there's also been increased mortality that results from the treatment modalities used for breast cancer. In the mid-1990s, in efforts to diminish morbidity and also cosmetically retain the breast, in early stage cancers, the therapeutic approach began to become that directed towards lumpectomy, followed by radiation. This has been found to produce some damage in the coronary artery tree, and also there's potential damage to the myocardium if the radiation is too intense. It's interesting, but the relative risk for those having left breast cancer relative to right who are treated this way is about 1.3 times on the left, which makes total sense when we think about the anatomic location of the coronary artery tree. And of course, there are also side effects from chemotherapy. Certain forms can produce a myocardiopathy as well. And also there's increased incidence of hematologic malignancies that result from chemotherapy. And it's been found that these effects persist over time. A good model to use in considering this phenomenon is that of Hodgkin's disease, and this has been noted for years. Here's a slide showing the response of Hodgkin's disease to therapy. We see that after about 6 years or so, recurrent Hodgkin's lymphoma really is not much of a factor. However, these individuals are treated with chemotherapy and also with mantle radiation and radiation along the para-aortic area in the chest that results in similar problems that we find in breast cancer individuals. That is coronary artery inflammation and lesions and increased secondary malignancies as well. And indeed, the mortality that persists from Hodgkin's disease is significantly larger than that from breast cancer. In truth, although there is chronic increased mortality in breast cancer, it's really of a relatively minimal degree.
What is the menopausal effect for breast cancer?
Well, it's been known for a long time that high estrogen levels increased risk for developing breast cancer. For instance, early menarche or late menopause, that is menstrual cycle lives that are associated with longer exposure to the effects of estrogen, increased risk for breast cancer. It's also known that women who have their first pregnancy after the age of 30 or do not have a pregnancy are exposed to estrogen longer and demonstrate increased risks for developing breast cancer. We also know that unopposed hormonal replacement therapy is associated with the same. And so it makes good sense that we would construct our underwriting guidelines to incorporate this natural phenomenon. That is, that we change our age banding so that group 50 and below is separate, that is the premenopausal group, from those that are in the postmenopausal age ranges, which we've age banded 50 to 69 and 70 and above. And here for the early stage cancers, we can see that there's a dramatic difference in mortality. Here you can see we've separated out T1As and Bs, grades 1 and 2, and the same grades for a T1C. And we can see there's a definite difference in mortality in the premenopausal or under 50-year-old group. And actually, for some of the postmenopausal age ranges, we can see that mortality ratios are flirting with a total standard mortality expression.
Rob, did you find anything significant for applicants over age 70, what we like to call mature age applicants for breast cancer mortality?
We certainly found a situation that suggested we need to change our underwriting parameters. And that is that many of these women now in the early stages are treated with lumpectomy and tamoxifen alone, and not with radiation. And also it's found that their lymph node status in the axilla does not require pathological evaluation, in other words, removal of tissue for evaluation under the microscope, if there is no clinical evidence of lymphadenopathy in the axilla. Now, here are some studies that demonstrate this situation. And again, these are mainly women with T1 disease. So when we're talking about this situation, we're talking about breast cancers of 2 centimeters or less in dimension. In those age 70 and above, with clinically no evidence of matted lymph nodes or enlarged lymph nodes in the axilla. And we can see that in this situation, when they're treated with tamoxifen alone, there really is no increase in mortality risk. And so this has become a much more commonly encountered therapeutic approach in elderly women, which certainly saves them from the side effects of radiation and the inconvenience as well. And so to make our underwriting commensurate with this more commonly occurring clinical practice, we've dispensed with the need for pathological lymph node evaluation in this age group, in this situation.
Is there any mortality variance for women that have undergone a lumpectomy and are being treated with tamoxifen?
In an early stage tumor. And this is a study that just supports that. Here we see on the left that one of the curves represents those that received tamoxifen alone after lumpectomy, and the other curve is those that received adjuvant radiation treatment and also tamoxifen after lumpectomy. And we can see there's really no significant difference, essentially no difference in survival. So this just supports the fact that lumpectomy and tamoxifen suffice for this situation. On the right-hand graph, we see that actually when compared to expected survival, which in this study is represented by this blue line, that actually the survival is a little better than expected in this group. Again, just supporting the fact that these women do quite well. Of course, in this age range, 70 and above, this is where we start to get into competing causes of death. So that this sort of mutes the effect of increased mortality risk that might be conveyed by these early stage breast cancers.
I noticed that some changes were made to ratings for node-positive disease. Would you like to tell us more about them?
That's true. We do insure some situations with node-positive disease. And basically, the criteria are we'll insure, again, T1 or T2 lesions that have up to 3 axillary lymph nodes involved. If the lymph nodes are not matted and freely movable, and obviously this applies only to ipsilateral lymph nodes in the axilla on the side where the breast cancer occurred. Now, of course, mortality is somewhat worse in this situation. And here we can see several expressions of this. This is a T1C cancer, again with lymph node involvement in the axilla. And now we can see that the survival curve assumes that concave pattern that we mentioned earlier. On the right is a T2 lesion also with positive lymph nodes, similar pattern. We can see the mortality ratios there are appreciably higher. T1C lesion, 169%, T2, 190. And because of the early increased mortality, the steepness of the curve there suggests that in this area of concavity that we probably would do well to have a postponed period. And so we will insure these people, but we do recommend that underwriting assessment is postponed until 3 years post end of therapy have transpired. In summary, to review the main points that we've discussed that are expressed in our new breast cancer section, we can see that when we have the convex survival curve that's usually present in early stage cancers, we can eliminate using temporary flat extras and rather underwrite these using the debit system. The very late development of the expression of increased mortality in these particular lesions also enables us to do away with the postponed period other than that 1 year after completion of treatment. And although we recognize that persistent mortality is present in early breast cancer, the degree is such that it does not appreciably affect many of these lesions, which actually demonstrate mortality ratios that approach standard. Also, we've changed age banding to recognize the very significant effect of menopause on breast cancer mortality, with the age band of 50 to 69 having significantly better mortality than those premenopausal years. The other major change that we want to remember is that in women that are 70 and above who've had only lumpectomy and treatment with tamoxifen, we no longer require lymph node evaluation pathologically, that is, looking at tissue under the microscope, if there has been no clinical evidence of lymph node involvement in the axilla.
Rob, thank you for your time and this great information. I am pleased that we are able to offer these improved assessments to you, our EDGE users. If you would like more information about the updates to our breast cancer section, please visit the What's New section in EDGE. If you have questions, please call any of our underwriters. You can find their contact information in EDGE by clicking the underwriting link located in the top left section of the manual page. A list of contacts will also appear at the end of this video. I hope this presentation has been useful to you, and thank you so much for joining us.
I certainly appreciate your attention, and I hope that this information is of good use to you. Thank you.